Good afternoon and welcome to today's program titled Transitioning from Meaningful Use to Meaningful Results. I'm Shannon Bryce, Associate Editor of Behavioral Healthcare Magazine. Today's program is sponsored by Core Solutions. Thank you to our sponsor and to you and our audience for giving us your time and attention. Before we get started, I'd like to share a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons at the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, simply click the red Q&A button. To download a copy of today's slides and other materials related to today's topic, please click the link in the Resources area in the upper right of your screen. If you have any technical issues during the program, please click the yellow Help button to troubleshoot. Good afternoon and welcome to today's program titled Transitioning from Meaningful Use to Meaningful Results. I'm Shannon Bryce, Associate Editor of Behavioral Healthcare Magazine. Today's program is sponsored by Core Solutions. Thank you to our sponsor and to you and our audience for giving us your time and attention. Before we get started, I'd like to share a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons at the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, simply click the red Q&A button. To download a copy of today's slides and other materials related to today's topic, please click the link in the Resources area in the upper right of your screen. If you have any technical issues during the program, please click the yellow Help button to troubleshoot the issue. At this time, it is my pleasure to introduce our speakers, Roy Starks and Ravi Ganeshan. Roy has enjoyed his career in the psychiatric rehabilitation, including direct service and management. As the Director of Reaching Recovery for the Mental Health Center of Denver, he oversees partnerships with other mental health systems and assists in supporting their transformation to a recovery focus. Ravi started Core Solutions nearly a decade ago. He began the venture as a developer of custom solutions for select organizations in behavioral health and human services. Since then, he has used his passion for entrepreneurship and a rich background in consulting and software development to grow the company into a premier technology provider for clients of all types and sizes across the country. Thank you both for taking the time to speak with us today, and with that, the audience is yours.
Thank you, Shannon. I want to thank everyone for joining our webinar today on transitioning from meaningful use to meaningful outcomes. Both Roy and I are very excited to have everyone's participation today. We have over 500 registrations for the event. First, we thought we were just famous and people are coming to hear us speak. Then we realized this really reflects both the importance and interest in recovery-based outcomes. Now, our goals for today for the 1-hour webinar are twofold. If your organization is in the early stages of adopting a recovery-oriented approach, we hope to have provided you with few ideas that you could use to accelerate this process. If your organization has already adopted a recovery-oriented approach, we want to share how an outcomes model can measure recovery. At the end of the presentation, we hope to have moved the needle forward for a couple of the participants, couple of the agencies in the call today. So briefly, the agenda for today, we want to discuss some of the industry trends that is driving outcomes. We want to then look at a brief introduction into adopting a recovery focus. Then I'll be handing this over to Roy, who will discuss the Mental Health Center of Denver's use of a recovery-based outcomes model and the tool they have created. We also want to spend a few minutes to discuss some of the common objections to implementing outcome tools. And hopefully we'll have some questions, time for some Q&A. So, there has never been a time in the history of our industry where so much change is happening so fast. accountable care and parity laws are actually improving access to behavioral health services. It is estimated that we will have 20 million newly insured individuals, and an estimated 25% of them will have a primary behavioral health diagnosis. Tied to this is the growing evidence how behavioral health interacts with physical health. You have all probably heard the statistics. 68% of individuals with serious mental illness have a co-occurring physical health condition. We also know that people with serious mental health illness die 25 years younger than the general population. So this is not just a quality of life issue, but also a cost issue. With the increased focus on behavioral health, there is also increased focus on outcomes. The next important trend is certification. The Office of National Health Coordinator is discussing new standards for certifying behavioral health EHR applications. As part of these standards, we anticipate outcomes and outcome measures be included over time. The other trend is on meaningful use. In stage 1 of meaningful use, it was all about collecting data. With stage 2 and the future stages, the focus has shifted to results. How is the data we are collecting demonstrating improvements in care? Finally, there is also a big focus on centers of excellence. Centers of excellence are not just individual organizations, but companies working together to treat consumers holistically. This requires coordination of care and a strong platform for information sharing with the ability to look holistically at client care. To be rated a center of excellence requires a strong, proven outcomes approach. So these are, important trends that we think supports the need for an increased focus on outcomes. Now, physical health and behavioral health outcomes are very different. Let's take a hypothetical situation. A person walks into a primary care clinic or hospital and complains of chest pain. You would probably get an EKG and other tests to determine the presenting problem. The patient is going to be placed on a medication and in a severe case might have a stent or a surgery. Now, at the end of this process, the same test will show an improvement in the patient's condition. Now, in the healthcare world, HEDIS is the most commonly used measure, and it looks primarily at the encounter data to see if the patient received the appropriate level and intensity of care. Now, in the behavioral health world, very different. Let's say a person walks into a behavioral health clinic and indicates he or she is depressed. First, we do not have universally used protocols to measure and treat depression. Further, the client might never recover from the symptoms. So the outcomes cannot be just focused on symptom reduction or management. We need to focus on other aspects like hope, resiliency to really measure outcomes. Now, that lays the case for a recovery-oriented outcomes approach. So what are some of the benefits of adopting a recovery-oriented outcomes approach? For the consumer, the biggest benefit is their own improved beliefs about the progress they are making. It's a way for them to see how they are progressing with their own recovery. This is therapeutic and accelerates the recovery process. For the clinician and for behavioral health organizations, an outcomes approach will allow us to spend limited resources in the most optimum fashion. We can move consumers with a higher degree of recovery to lower levels of care and truly spend time on individuals who need more services. Let's now talk about adopting a recovery focus. We have actually a poll question here. So if everyone could respond to this, does your organization have a recovery focus? If everyone could choose yes or no, I'm going to give a few seconds. And let's see, the results from the survey. So that's, very encouraging. 86% of the respondents indicated yes to the question about a recovery focus. So it's exciting for us to be further continuing this discussion. Now, recovery focus is not a clinical practice. A strong recovery focus requires the entire organization to embrace the recovery culture. Everything from posting signs in the office to how we talk with consumers in the call center, in the intake process, clinical, everything is impacted with this culture. Achieving this level of recovery focus requires strong commitment from management and also ongoing investment in staff training and development. Trying to implement the outcome tool that we are going to discuss today without the organizational readiness will not create the results we desire. That's why we've created an organizational readiness assessment to evaluate if this tool is appropriate for the agency. So what does a recovery focus look like? Now, the traditional focus in healthcare is to focus on symptoms and manage symptoms. This is certainly important, and we need to continue to do this. However, the recovery approach does something more. The recovery approach is person-centered and focuses on the individual's strengths to aid the recovery process. Recovery approach is not just a feel-good philosophy about providing services. Recovery principles are based on strong research. In fact, research shows that 40% of change in a clinical context can be attributed to the client's strengths. So that's strong evidence to support the recovery movement. Now, with this background, I'm really privileged to introduce Roy Stokes from the Mental Health Center of Denver, and he's going to provide a background on the Reaching Recovery's Outcomes tool. Roy?
Thank you, Ravi. Thank you very much. So I'll just go ahead and describe briefly the organization I work for, the Mental Health Center of Denver. So we're a large community mental health center in an urban setting, mandated to serve the most in need. So we serve people. Our top priority is people who are homeless, and then people who are in hospital or in emergency room, with targeted diagnostics of schizophrenia, bipolar illness, or major depression. We have intensive services for about half of the people. We have about 5,000 individuals in treatment at any point in time. And I'll talk a little bit more about those levels of care. We also have a large psychiatric rehabilitation program, so we believe that people's ability to move on to education and employment are a very important part of people's recovery. So back in about the year 2000, we had a new CEO by the name of Dr. Carl Clark, and at that time we began to talk about increasing our transformation to a recovery-focused system and what it would take to truly become a community mental health center with a recovery focus. We spent a lot of time doing logic modeling, trying to look at what we would look like if we were, in fact, a recovery focus. And then at the end of the day, kind of decided that we wouldn't know if we were an agency with a recovery focus unless we developed a way to measure that and look at progress toward that over time. So over then several years, we developed the instruments that I'll be talking about here in a minute, and we've been integrating those into agency practice, some for as long as 12 years, but some in the last 5 years. So let me move to the next slide and actually talk about the instruments we've developed. So it may be helpful conceptually to think of this as not just outcome measures, but three different types of processes. So the first one is the recovery needs level, and that is a level of care instrument. So that's kind of separate. The next two, one is called the recovery marker inventory, and the next one is a consumer recovery measure. Those two are actually what I would describe as true outcome measures. And then the fourth one is the promoting recovery in organizations. And that's where we do a survey of the people we serve and ask them the extent to which each one of their providers promotes their recovery. So I refer to that as the PRO survey. It's actually 7 different surveys. So a consumer would rate their prescriber on the extent to which they promote recovery. They rate their clinician, their case manager, their residential staff if they're involved in residential. They rate their rehabilitation staff, nursing staff. And so it's a number of different surveys. We're currently developing an additional survey where they will rate a peer provider, because we also have a peer mentoring program within the Mental Health Center of Denver. So the recovery needs level is the instrument that gets at utilization management and a level of care. So like many mental health centers around the country and many mental health systems, we have different levels of care. So back when we started this process, we had people that were being treated on assertive community treatment teams and intensive case management teams. And originally the belief of the assertive community treatment was that people would need that level of service for the rest of their life. We were seeing in Denver people that were recovering and we felt could graduate from assertive community treatment to a less intensive level of care. So we developed a system with 5 levels, the first being assertive community treatment with a staff ratio of about 1 to 10, 1 to 12. The second is intensive case management with a ratio of a case manager for 25 people. The third level is what we call enhanced outpatient, and so there would be case management services with a ratio of about 1 to 40. And then it goes up to traditional outpatient, which would be caseloads as large as 75 or 80, providing strictly therapy and psychiatric medications. And then the fifth level would be psychiatry only. So of those 5,000 people that are in treatment at any point in Denver, they're in those different levels of care. When we originally implemented this instrument, the first year we were able to graduate nearly 400 people out of assertive community treatment into less intensive levels of care. And that enabled us, with no increase in funding, to open up 400 new slots of services for people that were homeless and had mental illness in Denver who had not previously been able to get into services. So there was a huge cost savings as well as a strong recovery benefit for the people that graduated to less intensive services. And we've continued to graduate now about 300 people a year from the most intensive services to less intensive levels of care. And on average, that if somebody comes into treatment and they have a major mental illness and they're homeless, they most likely would be assigned to an ACT team. But on average, within 12 to 18 months, they would graduate to a less intensive level of care. So that's the recovery needs level. The recovery marker inventory is a questionnaire that the provider fills out. So it could be a case manager or a clinician. And it's they rate people on things that tend to correlate with recovery. So those would be areas of employment, education, symptom management, engagement in services, participation in treatment plan, housing, substance abuse, and we're adding a primary or a physical health care marker to that. So on the screen you're currently seeing what you're on the top one on the right, you're seeing that rating of people's progress in each of those dimensions over time. That also enables us to look at a recovery score. So this particular instrument is completed once every 3 months, and you can then plot a person's progress in recovery over a period of time. In turn, that enables you to look at people that are kind of recovering as expected compared to their peer group, or people whose recovery progression is faster than expected, or people whose recovery is slower than expected. And so you can plot that on a scattergram, which is the lower right-hand part of the screen that you're seeing. and use that for utilization management. The upper part of the screen, the markers results, would actually be shared with the consumer and used as part of a treatment planning process. The other instrument that's a true outcome instrument is the consumer recovery measure. And again, this is an instrument where the consumers rate their own recovery every 3 months, and it's on dimensions that tend to apply to all consumers. So we did not include employment or spirituality because that's not a part of the recovery for all consumers, but we did include symptom management, hope, engagement in services, safety, and social networks. And we had a lot of consumers involved in the process of identifying what those 5 dimensions were, and there was agreement with those consumers that those were 5 dimensions that applied to across the board to all consumers. So once a quarter, they rate themselves on their progress of how they're doing in those 5 dimensions with safety, social network, hope, and like I said. So again, we can plot that progress over time and then build that into treatment planning and address issues that the consumer wants to try to work to improve over the next few months. So again, it's in the context of a treatment planning approach where the consumer is seen either as a full partner or in charge of their own treatment plan, and setting their own goals and using some of this recovery data to help them think through what they want to work on for the next 6 months and what's going to be the most helpful. So that's the instruments. The Pro Survey we do once a year with a 10% sample, and then we provide that feedback to the treating teams and ask them to establish goals on how they might increase their recovery practice. So we ask them, one of the things they might consider doing is using Pat Deegan's recovery library to hear more stories from the person's point of view on their own recovery. But there's also a whole number of other recovery resources out there and recovery education. Along with this, we provide a set of training for all new employees of the Mental Health Center of Denver, and changed our mission statement back in 2000 to enriching lives and minds by focusing on strengths and recovery. So we don't just see this as applying to our clinical staff. We're interested in measuring engagement of staff at the Mental Health Center of Denver to see that all staff are committed to this recovery focus and committed to seeing people with major mental illness having a better life in spite of their mental illness. So at this point in time, I'd like to ask another question, polling question. Does your organization's EHR, electronic health record, support the collection of outcomes data? Yes, no, or we don't have an EHR. So again, does your organization's EHR support the collection of outcomes data? Yes, no, or we don't have an EHR. So I'll give you just a minute to answer that. And let's see what the results are. So yes, 54%, no, 11%, and then 34% do not have an electronic health record at this time. I think it's an interesting spread. I think that if you're obviously if you have an EHR that can collect data, that's going to, I think, be helpful. If not, that's something that can be considered. And then I think, for all of us over time, there's going to be increased pressure to develop EHRs and have EHRs that have meaningful use. So I think Ravi addressed that earlier, and that's kind of where we're headed with this. Thank you for responding to the poll. So moving on, this slide just talks about the fact that people do recover. as they move to less intensive services. So one of the fears is that if people move from an ACT team to a less intensive service, that things will go poorly, they'll end up back in the hospital, or their recovery will have a negative impact. And this slide is just demonstrating that, again, with the use in Denver, that's simply not the case, that people do graduate to less intensive services. And the path for recovery is kind of similar, irregardless of whether they come into an ACT team, which is this lowest line, or come in at a less intensive level of treatment. You typically see the most improvement in the first year to 18 months after intake, and then it levels off to some degree. Things that are of value in this process were obviously consumers being involved in the process. So we spent a lot of time training consumers on what it meant to graduate to less intensive services. Obviously, there's a financial benefit to the Mental Health Center of Denver, which could be replicated at other sites around the country. We currently graduate about 300 people from ACT to less intensive services a year, so that breaks out to a cost savings of about $3.6 million annually. So moving through, we're also able to report how ACT-level services save money, so that if somebody's homeless in Denver and they come into treatment, we talk about, and we're collecting data on emergency room visits, hospital visits, decrease in physical and psychiatric hospital days, decrease in jail days. So we do a lot of reporting back to our stakeholders about cost savings of providing intensive services to people. But then we also talk about graduating those people to less intensive services and how their recovery outcomes continue to show positive growth over a period of time. So let me move on then to talking a bit about common kind of objections or issues that might come up around implementing this kind of a system. So, some folks would say, well, we're not reimbursed for outcomes. It seems like these would be time-intensive. Capabilities like this usually have high costs. So, I understand that we're not directly reimbursed for outcomes, and at the Mental Health Center of Denver, we're not directly reimbursed by the state or by our managed care company to provide outcomes. But we are in partnership with them, and so they do see a tremendous cost benefit for graduating people to less intensive levels of care. So it's not a reimbursable service, but it is one that has a tremendous financial advantage both to the funding sources as well, the state of Colorado, the city and county of Denver, as well as the managed care companies. In terms of being time intensive, we intentionally designed these instruments to not take a lot of time. So because we developed the instruments using what's called item response theory as well as classical test theory, the instruments are very brief. So the consumer instrument is actually only 17 questions and takes just a couple of few minutes to complete. The one that is completed by the case manager, where they rate people's progress on in areas that correlate with recovery, like education or employment or those kind of things. Once a case manager gets familiar with that rating system and familiar with the definitions and how to ground it, again, that can be completed quite rapidly. And so I think if it's the kind of reporting that's just done and kind of goes into a black hole, then clinicians object to filling out those kind of forms. But if it's data that can actually be circled back around and built into clinical practice, and clinicians are able to see the use and the value of the information, then they actually feel like it's time well spent. And again, capabilities in terms of high cost. I think it cost the Mental Health Center of Denver a lot to develop these instruments originally, and we've invested a good amount of money and a good amount of time in developing these outcome measures. They're one of the few recovery-oriented outcome measures that's available, and they're also one of the few recovery outcome measures that was actually developed with item response theory and classical test theory, so that they have good reliability and statistical reliability and validity. So the developmental cost was high as we license these instruments to other community mental health centers or other providers. It's affordable, and so it's not an intent to make this unbearably expensive for other providers that want to partner with the Mental Health Center of Denver. And so we're actually in the process of doing that now. We have about 10 partners around the country that have formed a learning collaborative and are licensing these instruments and using the instruments along with Denver to assess progress of people as they move through a recovery process.
Roy, I'd like to add, one more point to this, which is, I think the world that we are in is changing so dramatically, and I think in the next, 5 years, 10 years, we are really going to be getting a lot more scrutiny than ever before. I think we are all moving, swimming with the rest of the healthcare world. And I think it's very important. The cost of not doing this is probably the way to look at it. We do need to be able to demonstrate outcomes. We do need to have a way of being able to talk to the primary care world, what all of this means. So as you look at, all the common objections, I'd also encourage people to, really, what is the cost of not doing this? What is the cost of not being able to report outcome measures that has both clinical validity and it is statistically proven? So I just wanted to, throw that out, Roy, as another point to consider.
Yeah, that's very helpful. And I think that, I was pleased to see that a number of the people on the call today already have a strong recovery focus within their environment. So I think that that the way this works is that an agency needs to understand the recovery literature and needs to understand the commitment to people having a full life in spite of their mental illness and returning to work and returning to school. And then these outcomes really support that whole process. So we're not just collecting data for the sake of collecting data. It's a process of trying to use data to inform clinical practice and drive that. One of the things I didn't really focus on, but I want to mention now, is that because with the markers and measures we're able to plot people's progress over time, we can also look at their progress within each one of those dimensions. And so one of the examples that we talk about is that when the prescriber, the psychiatrist or other prescribers, are seeing a consumer, oftentimes they haven't seen the person for 3 months or longer, and they don't have a lot of time to spend with the person. One of the ways this is used is they're able to go into their health record and click on a button that says Recovery Profile and look at the person's results, both in terms of how they're progressing on the recovery markers as well as the recovery measures. So an example would be a psychiatrist was meeting with a consumer and said, when I look at your recovery measures and the way you're rating your own recovery, I notice that your sense of safety has gone down dramatically since I've seen you last. And can you talk a bit about what that's about? And the consumer then talked about the fact that they had had a death of a parent, and as a result they had to move, and there was a lot of other things going on in their life. And so that led to a discussion then around implications for medications and implications on how treatment was going. And the psychiatrist's comment was that in a typical med management kind of brief interaction with a person, that might not have even come up. So it's another example of how you use this data when you are meeting with a consumer. Another example was a consumer who saw the same psychiatrist, and the psychiatrist said, "I see you're rating your recovery, actually lower than you were a year ago. It seems to me you're doing better than you were a year ago." And the consumer's response was, I am doing better. I'm doing much better, but now my expectations are so much higher that I've changed the way I view my own recovery. So it's, those kind of interactions that I think might not be as likely to happen without a data-informed system. So those are the kind of advantages that I see to using the system, and like I mentioned earlier, also just implications for treatment planning. So, Ravi, do you want to address this particular slide?
Sure. So, hopefully this gives some background. We have a lot of questions that we'd like to take time to discuss. But, this is a process, and depending on where your organization is, we want to take the next step. We want to help organizations continue this path. And we want to have, again, this is no cost, this is free. We want to have a more focused webinar or a workshop online, which will be, again, supported by Roy and his team at Mental Health Center of Denver, where we get into more details about the tool. How are other companies using these different tools? What do these tools look like? What are the kinds of analytics that are coming through? If your agency is interested, we would love to hear from you. I think we want to do this in small groups, so we are looking for the next or the first 10 organizations that would be interested in continuing this conversation. You see an email address on the screen. Please do use this to contact us with your interest, and we'll be scheduling the next session sometime towards the end of March. So just wanted to put that plug. And I have one other shameless plug. That is, if you click on the resources section in your window, you should see a link. We want to promote a movie on recovery. It's called The Anonymous People. It's being screened this Saturday. It's a story about recovery from addiction. We would love to have you, watch this movie. It is, again, free of cost. It's a 24-hour online screening. Name of the movie is Anonymous People, and you should see a link to a Facebook events page that would allow you to sign and get online tickets. So, hopefully that gives audience some other follow-up activities. Roy, back to you.
And I mentioned it real quickly, but I just want to mention again that for those of you who are familiar with Pat Deegan's work or familiar with Pat Deegan herself, her new product is called Recovery Library, and it's a compilation of individual videos of people telling their own story of recovery from mental illness, but it also has tremendous resources for smoking cessation and wellness and a whole number of other topics. So I would encourage you just to Google Recovery Library and take a quick look. So on the current slide, though, I want to address that, again, as Ravi mentioned earlier, the transition from meaningful use to meaningful outcomes. I think that we've found in Denver, our experience has been that, again, our stakeholders want very much to see recovery outcomes as opposed just to symptom management. So, I think we have turned the corner of saying that it's okay to treat people and your goal is just to help people stabilize in the community and stay out of the hospital to a real expectation where I think our consumers, the people we serve, the families of the people we serve, really have an expectation that community mental health centers will help people have a life in spite of their mental illness and move on that recovery process. So in order to really have a meaningful discussion around that, we obviously believe that you have to be collecting data. The recovery focus represents a process that is better suited for behavioral health. The recovery as an organizational focus, not just a clinical practice. Again, I think we've addressed that, but you really need everybody in your organization to be committed to a recovery kind of mission statement and vision. And then I think these outcome measures can help you reach that. So again, the recovery measurement process that we've talked about today can just help your organization increase a recovery focus or begin to move in that direction. I think I addressed the objections, but certainly I'm open to having more of that discussion as we move toward question and answers. So that's kind of an overview of what we've covered today. Ravi, do you have things to add to that?
No, I think that's a good summary, Roy, and I know we have different questions that have come up, and we'd love to hear from people and answer questions.
Okay, sounds great. Well, thank you both for a great presentation, and like you said, we have already had a number of questions come in throughout the presentation, but we will, be accepting questions throughout this whole portion, so please continue to use that Q&A widget below the slides on your screen to submit a question at any time. Okay, so I guess the first one we'll start with is someone was wondering, I guess this is a question for you, Roy, do you know what percentage of the population involved in your study was involved in local or state corrections?
I don't know the exact percentage, but I know that that it's a significant number. So several of the programs that we have at the Mental Health Center of Denver are actually jail diversion programs. So it's people that otherwise would have gone to the county jail, but instead, through the court system, were given the option of going into treatment. So we actually provided an assertive community treatment team to do jail diversion. And then actually our local sheriff county jail system was so impressed with the results of those initial studies that they used some of their money to fund additional jail diversion assertive community treatment teams. So that's a partial answer to the question. In terms of state corrections involvement, I don't have a percentage, but I know that we treat a significant number of people that have been released from the state correctional system and then are seeking community mental health services. So I apologize, I don't have a specific number for that, but I know that it's part of the 5,000 people that we're serving at any point in time.
Okay, great. Thank you. And I know you mentioned towards the end of the presentation, you talked a little bit about reimbursement for this, or I guess lack thereof. Do you think being reimbursed for outcome reporting will happen in the near future?
Again, I don't think it'll be a direct reimbursement, but I think, again, for us, we're in an environment where we have state general funding, but then we're part of a Medicaid capitation managed care model, and so we're demonstrating for the managed care company reduction in hospital days, reduction in emergency room visits, reductions in all kinds of things that would be cost to a managed care company, and then we're also able to report people's progress on a recovery pathway. So even though it's not a direct reimbursement, I would say that our funding sources locally love this approach, and the state of Colorado, although the state Office of Behavioral Health Care has not implemented this statewide, they're certainly interested in looking at these kind of results, to looking at recovery outcomes as opposed to some of the other outcome measures that we talk about. The other thing we do then is we're able to provide at the end of the year a report for our stakeholders and for our community that actually shows the benefit of an investment in treatment versus the cost of having people homeless and using community resources at a very high level. So again, that's another way that we use this data to demonstrate a cost benefit to the community. So it's not directly reimbursable, but I think you get a wide variety of benefits from including financial benefits from being able to report the data.
And Shannon, if I could add something to this question, I think if we just look in longer terms, this is reality today that we are not getting reimbursed for outcomes. But if you just look out 3, 5, and 10 years, I think we are clearly moving towards pay for performance. And I think there is going to be a change in our payer mix. There is going to be a change in how we get reimbursed. So I think the writing is on the wall. It's just a little further ahead. And an initiative like this takes, sometimes years to implement within the agency. So if we start taking the steps today, I think we'd be prepared for, the direction healthcare is headed in, pay for performance. And so I think that's something to consider for agencies. Does not impact us today, but, think 5 years down the line, I think it's going to start having a big influence.
Okay, great. Thank you. And you actually just mentioned something that I was going to bring up is just, how long does it take to implement an outcomes tool like this and develop the outcomes culture within an organization?
It took us a long time to develop it, but I think part of the benefit that we see with mental health centers that have now partnered with us is that it's a much faster process. So to some degree, I think it's a factor of the extent to which the partner we work with in terms of other community mental health centers already has a stronger recovery focus and a buy-in to recovery. And if there's already a commitment to recovery, then it's just a matter of implementing the instruments, and that can actually happen quite quickly. So, you can begin to look at recovery marker and recovery measure kind of outcomes immediately, and then by the time you have 3 data entry points, so over a 6 to 9 month progress time period, you're going to be able to track things like scattergrams and look at people's recovery trajectories and begin to build that into the treatment planning process and begin to have that discussion with consumers. The level of care instrument, again, can be implemented very quickly and has been implemented quite quickly by other entities that we're working with. So, for example, we work with a mental health center in Oregon that's moving toward a case rate kind of payment system. And so it's really to their benefit to look at an instrument that's an objective measure of a level of care that has some statistical reliability around it. And they were able to implement that recovery needs level instrument and look at their consumers within just a couple of months and really have a good handle within a couple of months of where their consumers scored in terms of projected level of service that they would need. So it can happen quite rapidly.
Okay, great. Thank you. Someone was curious if you were familiar with the Assessment of Recovery Capital, or the ARC tool, and if you are, they were wondering how this compares to your consumer survey.
So I apologize. I am not familiar with that instrument. Is that Ravi, are you, or do we know if that's an instrument that's used more in the substance abuse world versus behavioral health care?
I'm not really familiar with that tool either. So Shannon, if we could, just do our homework, and certainly we would love to get an answer to this question.
Sounds great. Yeah, no problem. Okay. Somebody else was wondering, I guess, in terms of the survey, who are the peer groups that you're using for the comparison, Roy? Are these other agencies or internal groups?
It's internal groups. But we can look at it. Part of what we're trying to do with the Learning Collaborative over time is really look at how the recovery process is different, perhaps in Denver than it is, across the country and other sites we're working with. So we're partnering currently with some agencies that are more rural, and we're interested in seeing if recovery looks different in rural sites. But in terms of the scattergram itself, it's based on a peer group of people that have similar characteristics and diagnostics and those kind of things. So it's a peer group within the Mental Health Center of Denver at this point in time.
Okay, thank you. I have another question about, staff giving feedback about what they think is best for consumers' graduating levels. Does the RNL allow staff to give input?
It does. The clinical team or a clinical program manager can overrule the RNL if they have other reasons to do that. So, but this is a very difficult question. So, when we first developed the RNL, if you went out and surveyed staff on assertive community treatment teams as to whether a person was, from their subjective standpoint, was ready to graduate, in most cases they would have said no. And so we intentionally wanted it to be a very objective measure, and again, if people want to take a closer look at the components of that, I could provide that another day. But the intent was to make it anchored on very objective kind of questions, so that it's not a subjective rating. And over time, I think we've been very pleased with the fact that it's not a subjective rating. Having said that, if there is some clinical reason that the person should not go to a less intensive level of care, the teams can make that decision. We also set it up so that the consumer could say, could appeal the process and say, I don't think I'm ready to graduate to a less intensive level. I want to stay on an ACT team. And originally we thought maybe 10 or 15% of the consumers would appeal the decision. In reality, it was only about 1%. And so those people were able to stay on an ACT team. And by the time they did their treatment plan again 6 months later, they were ready to graduate. So I think, our experience has been that that consumers' resiliency and consumers' recovery tends to get routinely underestimated by staff, and that as people graduate, bad things didn't happen. Their recovery projection actually improved. So I think it's really important that this not be a subjective decision by and large. But yeah, there is clinical teams can make the decision to keep somebody on an assertive community treatment team for a longer period of time.
Okay, great. Thank you for that answer. I think the next question is along the same lines. We had a person wondering, they said, how do we as counselors encourage clients to set their expectations at a level that is achievable?
Boy, we could talk a long time about that, but I think if you're following the principles of strengths-based case management, for example, the book out of the folks in University of Kansas, and looking at strengths-based work, the short answer is, you're always taking the consumer's lead on what they're saying that is the important thing for them to work on at that period of time. But you're also doing a lot of work around helping them see what their strengths are and having that discussion of, how to build on those strengths. So, so for example, in supported employment, a person may come in and say they want such and such a job that the provider thinks at that point in time is not realistic. But if you back up and talk about what their strengths are and what their interests are and what the characteristics of a job they want, it might not be that they start at, the ideal job, but they start at a job that slowly moves toward that ideal. And I think that applies to other things you might consider. So you're starting with what the consumer identifies as their strengths and what they identify as their focus of what they want to work on at a period of time, and you just partner with them to try to help them achieve that goal, whatever it is.
Okay.
So that's the short answer.
Okay, great, thank you. And then we had a couple questions come in about EMRs or EHRs, and people were just wondering, how does this tracking results in these different levels of care, how does that interface with your EMR or EHR, or does it interface with that?
Go ahead,
You want to go ahead?
In Denver at this point in time, all this is built into our EHR. So people they just go into the electronic health record, and the recovery profile pops up, and they get asked if they want to enter the data. They enter it directly into the electronic health record. The same is true with the recovery needs level. So all of this data is collected, and then the scoring comes back to them through their electronic health record, so they're never leaving the health record. With some of our external partners currently, the results are made available through a website, so they actually have to leave their health record to access the data and see the reports. But ideally, it's built directly into the electronic health record, and people are able to access through that format. The one that stays outside of the health record, obviously, is the Pro Survey. So when we do the Pro Survey, we actually hire a team of consumers as temporary employees of the Mental Health Center of Denver and train them on how to do surveys, and then they, in turn, go out and survey other consumers. So that is a pencil and paper process that does not go through the electronic health record. It could be done through pads or other survey kind of instruments and gathered electronically, but that's not currently how we're doing it. And Robbie, do you want to add to that?
Yeah, I want to add, first, I think it's very important for this to be tightly integrated into the systems that organizations use, EHRs, EMRs, because it has to become second nature to the clinicians, to all the staff in the agency. And I think so it's important to integrate this into existing workflows and not ask people to leave their current systems and go do this outside in a different world. I think that disconnect really hampers utilization. So I think that's one point that I wanted to make. And the second point is, as these systems evolve and more intelligence is gathered, there is a lot of opportunities for systems to take the information based on the different levels of care assessment and have decision support rules that drive the different levels of care. So if someone has been, progressing well in their recovery and there has not been really a shift in their level of care, I think decision support rules can help users identify, how to optimally use the resources to treat clients. So maybe it creates a decision, rule to say this individual has been at this level of care for, over 180 days and has continued to show progress. Please consider, a more appropriate level of care. So I think in the long term, integration with the EHR is very important, and I think the outcomes can help clinicians appropriately look at clients who need to move across levels of care.
Okay, great. Thank you both for that. I guess we have time for one more question. Someone was just curious if the state of Colorado has any mandated level of care instruments independent of, reaching recovery, and if so, how do these conflict?
They do not. The state does not have a level of care. The state does collect a lot of information through the Colorado Client Assessment record, but they do not have a level of care system. I am aware that some states do. I think, for example, Indiana has a statewide level of care instrument. And I think that as Oregon moves toward a case rate system, they're trying to look at how to assign those levels of care. So they're looking at instruments. My initial feeling is that the RNL that we're using is going to match pretty well with the levels of care that Oregon is looking at in terms of a case rate system. I'm not sure how our instrument compares with a level of care instruments that's used, for example, in Indiana. We haven't done direct comparisons in that state.
Okay. Great. Thank you very much. Well, as I said, that is all the time we have for questions today. If you enjoyed today's program, please join us on Wednesday, March 26th at 1 o'clock p.m. Eastern Time for another Core Solutions webinar. This one will be titled Addressing Increased Demand for Mental Health Services Through Mobile Technologies, and it will be presented by David Smith and Robert Capobianco. A link will appear on your screen in a moment for you to register for that program. You can also register for the event by clicking the purple Register for the Core Solutions webinar widget at the bottom right of your screen. I want to once again thank Roy and Ravi for an excellent presentation. I would also like to thank our sponsor, Core Solutions, for making today's program possible. Finally, thank you to you and our audience for participating today. We hope you will join us in the future for another behavioral healthcare webinar. This concludes today's presentation.